So how many people here are employers responsible for a covered population? Okay, so you have a choice of how you want to decide your benefits, what you want to offer, who you want to offer, what systems, what plans, what products, what vendors. So what I want to talk to you today is what those choices represent, what the impact is, and what lies ahead for you. We're going to focus primarily on high deductible health plans and what makes or breaks them. And then I'm going to talk about leading challenges employers face through beyond CDHPs, because there's a lot going on there. So again, a little bit about my organization and what we're going to cover. So at the end of the day, we're going to cover why high deductible health plans are important, that in fact they're going to be offered by the vast majority of employers, with about 30% at this point, making them the only choice that employees have. But to emphasize that to be effective, you got to do it right. You can't just throw it out. You can't just go from one plan, PPO or HMO, into a high deductible plan. If you don't do it right, if it's not structured and communicated right, it will fail. It'll cost you more than what you've been doing before. Employers need to focus on a variety of things. You've got to also look at optimizing your provider strategies, how you work with doctors, with hospitals, with PBMs, how you work with others. At the end of the day, you don't buy your raw materials from poor quality suppliers, your glass, your steel, your rubber. So why would you buy poor quality health care? Employers have to have the mentality as purchasers that you have a fiduciary responsibility as a ERISA self-funded company to be responsible for the quality of care and the quality of the providers and vendors you use. And it's important you recognize that. You cannot delegate that to somebody else, to a consultant, to a broker, to a plan. You, as a self-insured employer, have that responsibility. And there's lots of key challenges that we're going to address today. So, again, my organization, we're a 501c3 nonprofit located in Chicago. We've been around, this is our 36th year. We represent a large number of companies. We focus on helping employers get more value from their benefits, improve the health and productivity of the population, and have to address the local cost, quality, and issues in the local healthcare system. So our members spend over $4.5 billion in healthcare. They're focused on moving the mark. They're focused on getting their hands dirty and involved in what healthcare is all about and health benefits and the lives and future of their employees. These are not companies that are sitting on the vine waiting for somebody else to happen. These companies are the 24, 25% that are leading edge, what I call cannonball companies, willing to take a chance knowing the data that they have in their own population that identifies the kinds of costs, the problems that they're facing, the challenges, that they need to address that, and they need to do it in a proactive way. And that's what we're going to talk about today. My other organization, National Association of Worksite Health Centers, NAWIC, we found through our benchmarking surveys, and we do benchmarking of employers' directions, which I'm going to talk a lot about today, as well as other things, and we found over 30% of our members had some form of on-site or near-site health care. And they were actually delivering care at the work site. 60% of them were using nurse practitioners or physician assistants. 60% are not charging anything at all for the services they provide, not for the doctor services, the nurse, the drugs, the imaging, anything. They offer physical therapy, they offer dental, they offer chiropractor, acupuncture, as well as medical and all that. It is a growing trend, and we created this organization nationally for employers who are interested and also their partners. So if you want more information about how to get involved in offering on-site care at your site, let me know. By the way, we have companies as small as 100 who have a nurse come in 1 or 2 hours a week, and then we have companies like Disney and Target who have 24,000 square foot operations that offer the whole plethora of services. You can do it. It doesn't have to be large employers. It's something to think about. So we're going to talk in general about the role and challenges, the way it's going to do. I'm going to give you a broad perspective on about the high deductible health plan world and what we're seeing. So at the end of the day, people are saying, why employers are even doing this? Wasn't the purpose of Obamacare just get out of this? Why should employers keep the most expensive thing, the second highest cost other than payroll? Wouldn't they want to give that up? And the frank answer is no. It doesn't take a rocket science. Employers offer, you offer health care to recruit and retain talent. I don't care if you're Joe's Print Shop and you're competing with other print shops for truck drivers, Or you're a major corporation and have a chief negotiator, CFO, et cetera. If you don't have high-quality benefits, your people are going to walk. In fact, getting back to the on-site clinic world, in Silicon Valley, when we have Yahoo and Apple and Cisco and Applied Materials and Qualcomm, if you don't offer an on-site clinic that has massage therapy and chiropractor and doctors are on roller skates, they don't want to work for you. They want to be part of that. And so depending upon your environment, it's really going to be key. Other thing, productivity. Isn't that what it's all about? If you don't have healthy and productive people, if they're not physically and mentally able to work, you won't produce your product, you're going to have accidents on the job, you're going to have poor customer service. You have to have quality people, and we know insurance is required to do that. You have to incentivize your people. How many people offering benefits and wellness programs and nobody's going to them? Well, you have to offer incentives, and outside world doesn't do that. We have to reduce lost time. We have to reduce absenteeism. We have to create health, particularly for those younger people coming to work for us. When I joined MBGH back in '91, chronic disease was only among our employers who were heavy manufacturers or who had populations in their 50s. Now, people entering the workforce have diabetes, have obesity, have other kinds of issues. We have to address that early on. I don't care if you have 100% turnover or not. You have to address these problems early because in a community, you're going to get all kinds of people coming in. And of course, safety issues. You know, employers, we put a lot of effort on safety at the work site. No accidents. Well, again, if you don't put the same kind of emphasis in your wellness programs to keep people healthy physically and mentally, you are going to have accidents. So it should have the same kind of priorities as you have otherwise. Now, currently, it's not like employers are not involved. You are doing or you are paying people to do all of these things right now. Preventive care, wellness programs, risk identification, education, chronic disease management. You're doing these things and you're paying people to do it. So you better have some control on it because this is impacting your bottom line. If you don't have healthy people, if you're not buying right, if you're not structured right, if you don't incentivize people to use it right, you are going to be throwing money out the door. You can't afford to do that. And you got to be able to do these kinds of things to be successful. And as purchasers, you have to recognize that you can't be wimps, okay? HR people cannot be wimps. You're dealing with a healthcare system, okay, it's your system, that has the docs, can control the supply and the demand. You have to set your expectations as purchasers of healthcare. Employers pay the payers. It's not the health plans. You're paying the health plans to pay the doctors and hospitals who provide care for the patients. You're the ones who design the benefits. You're the one who decide the contributions. You're the one who decide the network. You want narrow network or broad network? You're the one who select the vendors. You're the one who values productivity. You have got to set your expectations for everybody you work with. And let the health plan, I don't care how small you are, you let that health plan know that what you want. We have a user groups of employers who have the same health plans. The Blues control 70% of the market in Chicago. So we have a Blues user group, and we have a United Healthcare user group. And we have employers who are large and small. And what we find is that depending on your account rep, you're either getting lots of services or no services. You find about new resources and programs. But by coming together as groups of employers, they share information, they share knowledge, and they use their leverage to make a difference. That's something you need to look at. Leading employers communicate their expectations. And if you want to do that, just like you do for any other supplier, you'll be successful. There's lots of things we're challenged against. Most of you are dealing in a global marketplace where other companies located outside the U.S. don't have to pay for health care benefits. You have to assure people have access. Under the ACA, we have another 30 million Americans who now have health care coverage. They're looking for primary docs and others as well. How do you ensure that access? How do you identify who are the quality and the safety-driven health care systems and providers? We know there's tremendous variability in health care and in quality and in cost, not just among hospitals and doctors, but even within the same hospital system, within the same medical groups. How do you address that our population is in a system that is not generally coordinated, that is fragmented, and that people have no idea, they don't know how to navigate the system? And many of us rely on health plans as our agents because we don't have the contracts with the hospitals and doctors and vendors. So you better pick the best kind of plans you're working with. Internally, chronic disease represents 80% of our costs. So I don't care how much you're putting in primary care, you've got to address your people with long-term disease. I like to say that someone with diabetes, for example, owns that disease. Because in general, if they stay under medication, if they monitor their eyes and their limbs, if they follow their doctor's orders, watch what they eat, potentially they could save their eyes, save losing limbs, saving themselves going on cardiac problems, going on dialysis. How do you help them to do that? They're on 5 to 12 medications and things like that. We have to work with our doctors, our hospitals, our vendors to support people. We have to motivate people. Only about 30% participate in our wellness programs. How do you incentivize people to get engaged, to be concerned about their own health? How do you provide access to people? And how do we avoid the ongoing 2020 excise tax? Fortunately, both presidential candidates are opposed to that, so maybe there's an option there. But you have to know this, and you have to have your own data. Do you know where your data is? Do you know all the vendors have a piece of your data? Do you ever bring them together to see what the totality of your population is, what the disease is? You should be focusing on population health. That's our challenge. But if you're like many of my members and you have a separate silo of data and staff for workers' comp and group health, and they don't talk to each other, you're going to have some real problems. You have to be able to merge, know your population, know what all your plans are doing, your PBM, your vendors, your EAP, who's got your care, your HRAs, health risk assessments, your biometric screenings. One of our members is the Metropolitan Nashville Public Schools. They actually even put in performance evaluations of their teachers as well as the health care. There's lots that you'd have to look about. So what's the status of our workforce? We know that people are sicker and they're coming in. We know compliance is poor. We know participation needs to be challenged. Physician I respect said, wellness is a chronic, relapsable condition needing constant attention. That's what you have to think about. It's not something people focus on. So let's talk about high deductible health plans. What's the great things there? Well, when we do surveys of our members, number one is, how do I avoid that excise tax? That was where they were going. That was before the extension has come about. You can see these are the priorities my members give. And then the question is, where our employers want to motivate behaviors? It's with consumer-directed health plans. It's getting people aware of their responsibility and getting them engaged in making decisions, not only where they get care, but how often they get care. And they need to do that. They need the information to promote that. National Business Group on Health, made up of the largest employers in this country, in their study said full replacement is the #1 way to hold down your costs. Offering a CDHP is the second major option. Increasing cost sharing. But all of these things have problems and challenges. The more cost you put on an employee, the more they're going to think twice about spending that, because many of our employees have to use that same money for food, for housing, for transportation, for books for their kids at school. What's the balance? That's the challenge we face. PPOs still are the predominant way. Most employers are still focusing. This is looking at the last 3 years and where they're going. But continually, CDHP is going to be a predominant part. I still believe it won't be the predominant one offered by most employers as an only plan. In fact, we have situations where employers are going away from CDHPs because they failed. So what we're going to talk about today is ways to make sure they make it. This is from the Kaiser Foundation. This is all employers, large and small. So you can see it's a little bit smaller than large employers. But when we look at CDHP options from, again, National Business Group on Health, and these are large employers, increasingly you're seeing full replacement, just like those who were around when HMOs first came out. Started small and got larger. I think we're going to find that here as well. So what's the value equation? Why are employers looking at it? Well, for those who are not familiar with a high deductible health plan, it's a pretty simple structure. It's a PPO built with a health fund, either a health reimbursement account or a health savings account. Generally offers what has to offer free benefits, preventive benefits as other plans. It has to include consumer support tools and information. You should be providing transparency information as well. Contributions are made to a general fund, and then depending on whether you're an employer, they either roll over or they don't. The employee makes a contribution or they don't. Participants are encouraged to use the tools. And some employers are making that more of a mandatory activity. You will go to this website and look this up before you get your benefits. You will go to our on-site clinic first before you go other places. So there are different ways that you can do that. If you're going to be successful, you've got to have the four structures. You've got to have a strong cost-sharing plan design arrangement. You want to be able to show both the consequences and the rewards of making the right decisions. You want to have the support tools there, because otherwise people will not know what to do. They won't know where to go. They won't know what it's going to cost. They won't know what its impact is on their total benefit design. You want to offer some kind of contributions. You don't want it too large, but you want it still to have game. But those employers who don't contribute at all lose, because people don't get care. And you want to have programs that really encourage people to involve, more incentives, testimonials, what people are doing. It's a little hard to see, but generally what this shows is the amount that employers are contributing both to high deductible plans and HSAs. And you can see there's a broad range, but clearly contributing a lot, and it doesn't say what the deductible is, of course, and what percent, but the more you can contribute, the earlier that you can give people money to spend so that before they're spending out of their pocket, the more people are going to use the plan. Employees generally not taking advantage. You can see many employees are not saving money. They're not recognizing that a high deductible health plan, a health savings account, actually can be, there's no tax on the money that goes in. There's no tax on the generation of the revenue that your savings are. And when you pull it out, there's no tax. It can be a retirement savings account, a medical savings account. So particularly for those who don't have retirement plans, it can be helpful. So from the employer perspective, looks like a no-brainer. You can literally budget for your health care. You offer it, and many employers don't offer this, unfortunately, as the lowest cost premium option. If you want people to get it and you're offering multiple plans, it's got to be a low option. If it's full replacement, it is going to reduce your costs. There's no doubt about it. It does set up your way for defined contributions. It motivates employees to start thinking to be real healthcare consumers. You know, it's funny, we find that people, when they don't have a sickness or a condition in their family, they're disciplined, they do research, they look about conditions, they look about providers. But when the doctor says, you've got diabetes, you've got cancer, all of a sudden, they switch to a consumer, from a consumer to a patient, and the emotions take over, and they don't know what to do, they don't know where to go. So it's important that they have support and understand that. CDHP will reduce emergency room use because people will recognize that's the single highest cost area in the healthcare system to get care, particularly for non-emergency reasons. People will understand the value of the investments. And it does create opportunities. But the impact by itself, as I said, could be a problem. It will reduce utilization. Many people, if they don't understand that their preventive benefits are still free, will not get care. They'll postpone it. This is going to change the way people are thinking about their lives and about healthcare. It used to be, well, it's $10 for a baby, it was $5 for a drug. I don't have to worry about it. The employer will pay if I get sick. It's a different situation. So there's some employees who are going to feel you as an employer have withdrawn from that relationship you have with your employees. That in fact, you're taking something away from them. That all you're doing is shifting your cost to them, particularly in a union situation. The rollout itself requires more education, and not just a month before, but almost 18 months before. You should be educating your people. This is coming. This is the cost on the employer. There's a link between health benefits and salary. It's not a fringe benefit. It is part of total compensation. How many of you are really thinking and providing your people with information on what the cost is of benefits and what they're getting out of and how that's on top of their salary? Many of you probably aren't. If you don't effectively communicate this, you will lose. You'll end up having lower employee satisfaction, low recruitment, and poor use. People will not get benefits. They don't understand how this works. You have to educate them. There could be much higher medical costs down the road as people don't get care, they don't get the drugs, they don't adhere to the medication, they don't follow their doctor's orders, and they end up in the emergency room for preventable conditions. So you've got to focus particularly on those chronic disease people to show them that, in fact, this is a way that they can improve their care, save money, and save for retirement as well. So are we leaving employees at risk by offering high-deductible health plans? Well, maybe. Maybe not. It depends. It depends on you. You have to understand the problems that workers face and how they perceive what you're rolling out to them. You have to help them understand where they don't. You have to get by the confusion that exists there. You've got to be smart about the rollout and the ongoing education. You've got to be able to help address the issues that they have, or it will push back on you. Learn from the defined contribution experience. Employers started rolling out defined contribution retirement plans. And they gave all this information and all the support, and people were saying, whoa, I don't understand this at all. You know, it's too much information here. I don't know if I should be contributing here. The people who were smart financially used the information and did well. Many continue, even though all the resources, all the support, all the advisors we throw at them, people still have trouble understanding what to do with their money. It could be the same thing with a high deductible plan if we're not careful. Over a decade ago, Great West Health did a survey of the employees who first were rolling out high deductible plans. And tell me now if things have changed a decade later. In 2006, people said they were unaware of the true cost of health care. They were unaware that they were accountable for what the costs were. Those who had saved often had too little money. That many were totally unfamiliar with how their plan worked. They didn't use the online information. 40% thought that they could control whether they got sick or not. Many thought they were already effective consumers and they didn't need any help. Most saw this strictly as cost shifting and didn't believe what the employers were saying. Huh? Is this yesterday or is this 10 years ago? So when people get into this plan, and if you educate them, they will use it right. Actions consumers make, again, showed here, once they understood that preventive care was free and how to use their benefit, they started using it. Most decided they didn't want to postpone care. They understood that this is a good thing, and when they had options, most were beginning to re-enroll. So we continue to see that it's possible. If you have a good plan, you have happier employees, you have healthier employees, and you have effective consumers. Contribution strategies are fundamental. I had a number of employers who rolled out the plan and didn't contribute anything at all and wondered why only 20% of people enrolled. You have to give a predetermined amount. You have to let people know money is going to come in. It's got to be part of your benefit strategy. If you want this successful, you have to do a contribution. The more the people can see that they can roll over money, that there's money left over, that perhaps they're not spending as much as the total that's required, they'll be better. So to promote your high deductible plans, you really have to address this to change the confusion, to make sure that people feel prepared and are ready to take that responsibility to select when they get care, how they get care, and what it's going to cost. You have to understand that people still have not only health literacy issues, but benefit literacy issues. We got a grant from the Commonwealth Fund and had a group of consumers that were sitting at computers, and we said, try to find a doctor at your health plan or go to your hospital's website. See if you can find a physician for a problem in your family. At the end of the day, I had a guy come up to me and said, look, my son cracked his knee playing soccer. I went to the health plan website. I went to the hospital website. I couldn't find a physician who fixed broken bones. Why? He didn't know what orthopedics was. And there was no glossary anywhere. So all this resource was for naught. We have to understand where people are. We have to make sure they understand the terminology and educate them to use the tools. You can have the greatest transparency in other tools, but if people don't know how to use them, if there's not a tutorial, if you don't work with them, they won't do it. A lot of people only learn face-to-face. I mean, as HR people, we've moved a lot to electronically, to online, to email, to text, to video. But at the end of the day, people want to talk to someone about something as important with this. They want a face-to-face. They want to ask these kinds of questions. You have to be prepared for that. You need to show how deductible plans can save them money, time, and give them much more options. If you can show their cost under the previous plan, the PPO, and what it would be now, and that in fact they're actually saving money, it'd make a difference. You've got to have different scenarios for different generations, for different people like the community. We've done studies and found people who are older want to be communicated different than people who are younger. Heck, some of the people that I work with now, they don't even look at emails anymore if it's not by text or Instagram or something else. They don't get that information. So how you communicate benefits is clear. It's a key area for you. You have to demonstrate the value of this. You have to show them case studies. You have to present testimonials. You have to promote how they can use the funds that they have. So let's look at some lessons learned. Number one, you can't communicate too late. You've got to give yourself plenty of time. You have to tell people where it's going on. You have to have a strong message and voice to say, this is how it's impacting the company, this is how it's impacting your salary, this is the value of it. Employees tend to look to the employer for guidance in healthcare on a lot of issues, and you've got to have a strong viewpoint. And you've got to link it to your programs. If you've got wellness programs and you've got incentives, make sure the payment of those incentives goes into people's accounts, their savings accounts. Don't just give them a cup, don't give them a trinket, don't just give them a gift card. Link everything back to that HD plan. Make sure that everything is linked together. Controlling costs has to be a combination of everything you do. So if you're going to have a successful rollout, leadership has to be visibly committed and participate, just like in any other benefit program you've got. They've got to be the first ones signing up. They've got to talk about it. They've got to be taking advantage. You have to make sure your benefit strategy is clear, whether it's one-off or a total or replacement. You've got to tell them where the coverage is. You want to show them models of people like them, their age, single, family with the kid, single individual who's by themselves, older and younger. You want to have continual communication about how it works and testimonials. You want to talk not only well before, during, but also afterwards. Let people know what's going on. Give people information that they can use. Keep them engaged in their care, and make sure you rehearse what you're doing. Okay, there are challenges. Okay, so we're assuming I'm not here for Carolina healthcare system, okay? You have to be concerned about your providers. What is the strategies? There's merging healthcare systems, there are ACOs, there's medical homes offering all kind of great promises of coordination. But how many of these have just got a plaque on the wall that said, well, we're an ACO now, we're a medical home now? How many are truly integrated in clinical matters? How many are truly integrated in procedures and how they're dealing with? Seems like only the bigger organizations are getting involved. There's a huge fear that this consolidation, again, as a purchaser, removing competition. If there's less competition, that's an issue. You know, how many PBMs are there now? You know, how many health insurance plans will there be? With more people getting coverage, it's cutting down our access. How are we going to address that? How are people getting connected? It's great to have a lot of telemedicine and other things, but is it another fragmentation of healthcare? More people going to retail clinics, urgent care centers. There's a great technology. More people have smartphones than have cars now. But people are confused often by the complexity of the healthcare system. There's all kinds of things we have to be concerned about. Employers need to find the best way to optimize the doctors, hospitals, systems that they're using. Centers of excellence seems to be an area that a lot of employers are going into. And not just, it used to be bone marrow transplants, heart valve. Now it's a plethora of different kinds of services. They're looking to increase or decrease payments to providers based on performance. I worked 17 years for the Illinois State Medical Society looking after the interest of doctors. And when I was at the Medical Society, we used to say, well, you know, there's a bell-shaped curve on performance in any area. And you have your very high-performing doctors. Most of them are in the middle of that bell shape. And at the end of that curve, you got low-performing. And as a medical society, we have to move those doctors up to the middle, make sure that, because once you have an MD, we're all the same. Now that I'm on the purchaser side, I'd say, no, we're cutting that bell-shaped curve in half. We don't want to contract with those people at all. We only want top performers. So if we're going to go into narrow networks, we want high performers, high quality, evidence-based medicine. We want to work for those people working for us. Using incentives, you're finding many employers now saying, okay, we will send you and your spouse or your partner or a friend to another center to get your cancer treatment, to your heart valve transplant, to your orthopedic care, for your cancer care, for your diabetes, and we'll pay for it all in a bundled payment. And we'll pay 100%, but if you don't want to take it, you got to pay most of it or all of it. So employers are building in incentives and penalties for people to take advantage of these. Talked a little about on-site clinics. I want to show you just 2 slides. We asked employers who had on-site clinics, what is the value? Is it meeting your objectives for lower cost and improved wellness? And here you see, and the way you read this chart, the blue bar is those employers who have less than 1,000 employees. The red bar is those who have 1,000 to 10,000. And the green bar is those over 10,000 employees. When we ask them, what has been the value in your wellness objectives of your on-site and near-site clinics across the board, you see better integration, better employer health, better access to care, reduced emergency room views, higher engagement, increased satisfaction and retention. And it's interesting, these centers become the most valued benefit employees have, even though an employer doesn't set out for that. Then we ask them, how's it affected your bottom line? Again, across the board, reduce hospital admissions, reduce emergency room costs, reduce pharmacy costs, reduce time off. We find when people have to leave work to get their blood pressure checked, pick up a script, take their kid for an ear infection check, they're gone. They take the elevator or they get into the parking lot, they drive in traffic, they get to the provider, they wait there, they drive back, they go home, they feed the dog, they're gone 3 to 4 hours, they don't come back to work. If you have a service nearby or on-site, you can improve tremendously and you can reduce lost time, reduce absenteeism, etc. But if you have an HSA, you better know that you've got to charge them something. Under the law, people will be ineligible for their HSA if they are given free services at an on-site clinic. So while over 60% of employers don't charge anything, you have to charge what they call fair market value. Now, I met with the IRS not too long ago talking about the excise tax and on-site clinics, and they don't have a firm definition of fair market value. And our survey shows employers charge as little as $10 and as much as the Medicare rate. But you have to charge something. But it's important to know that if you're going to get into this game. Other key challenges: specialty drugs, biologics. It'll represent maybe 1 to 2% of your population, but will consume 50% or more of your total pharmacy spend. You must get a handle on managing specialty drugs. The idea of biosimilars are coming out. They're not the same as generics. There'll only be maybe a 10 to 20% savings. But when they're coming out, it's time to look at, talk to your PBMs, talk to your pharmacists, talk to your health plans. You need to understand what is involved here. It's got to be focused on, you have the right kind of benefit design to use a specialty pharmacy that can educate the providers, educate the patients, help you. Do you have incentive programs for people? Do you educate people on how to stay adherent to these drugs? We are encouraging employers to build in benefit designs that say you don't get a 90-day prescription of a specialty drug the first time. You get maybe a 7 or 14-day, because many of these people will try the drug. If they get a side effect or they don't like it or it's the wrong dose or wrong setting, they will throw out that 90-day supply. And at $5,000 or $10,000 a month, you're throwing that out. So a limited initial fill, making sure it's the right patient, the right quality, right dose. Also, infusion doesn't have to be in a hospital. For some patients, it could be at a doctor's office. It could be outside. It could be at home. You need to look at site of care. But most of the drugs coming out of the pipeline is for oncology. By the way, most of the oncology spend on these biologic is in the medical plan, not the pharmacy plan, so you have no idea what that is. And you won't get that information. You want to try to move a lot of those drugs outside, away outside of the oncologist's ability to purchase and sell it back. We've got to find better ways to address biologics. Moving from wellness to well-being, we have learned that wellness program helping people at the work is not enough. They're worried about housing. They're worried about food. They're worrying about transportation, safety in their community. We have to shift our mindset into a well-being approach. You know, the business setting, the work site, is part of the total public health system. Over half of our people are getting their care at the work site. You've got to be able to address that. You've got to focus and understand that behavioral health, the mental conditions of our population, is impacted by every time they have a condition, mental health is a comorbidity. You have to address that. Many of our employers are now talking about resiliency, not stress, not depression. How do we help people be resilient, get back to care? You can often have a good conversation. You need to talk to your EAPs about this. We need to shift our focus from benefits to a total employee experience. We need to support patient decision-making. As more and more employers use consumer-driven plans, we need to be able to give people information on who are the best doctors, and not necessarily who's got the best reputation or who's got the brand name, but who's got the best results. Same thing with hospitals. Well, there's a number of transparency vendors. There's also free sites like Fair Health and others that are offering free information on the range of cost of services. We've got information on what other patients are doing. There's even one vendor who offers how doctors are getting treatment, how they're making decisions between choices. People need to know what they're going to be paying out of pocket. One of the biggest failures of our public marketplace, our exchanges, has been people have looked at the lowest cost premiums of those plans, selected those, and found out they have a $6,000, $7,000, $8,000 deductible. You need to know what your out-of-pocket costs are going to be for everything. Impacting the supply chain. Hospitals and physicians are consolidating. PBMs are consolidating. Carriers are consolidating. There's a movement now among employers to address the supply chain. One of the biggest problems in specialty drugs has been supposedly the pharmaceutical manufacturers. But when you peel the onion of the drug going from the manufacturer through the chain, to the patient, there's a whole bunch of middlemen in there. And each middleman builds in their revenue, their margin. We have to address supply chain, whether it's PBMs or whether it's health plans, whether it's hospital care or other types of care. You've got to look at the supply. In fact, there's a new organization called the Health Transformation Alliance that now has 33 of the largest employers in this country looking to get over the supply chain to determine what's the value of each of those middlemen, each of the players. It'd be valuable for you to keep track of that. So what are employer directions moving forward? Telemedicine. Close to 60% of employers are going to have some form of telemedicine. Because so many people have smartphones, you could do teledermatology, telebehavioral health, primary care, acute care. It's fascinating now. You know, you have someone who's, say on the weekend, you've got a mother, she's at the soccer game, but she's going to go to France next week for a business treat. She starts feeling a cold. She gets on her phone. Within 10 minutes or less, she gets a call back from a physician who looks at her throat with the camera, gives her a prescription she picks up, and so she doesn't have to miss a beat. Using a telehealth as an extension to give people 24/7 operation is great. Now, it's not licensed in every state. Not all of the vendors do it a little bit differently. The average cost is about $40, $45 a visit, but you can, as an employer, contribute toward that, make it free, or it's just another copay. It becomes very popular. But just like any other wellness program, if you don't communicate it, no one's going to use it. We've had nurse call lines for over 10 years, and maybe 10, 15% of people are using them. You've got to tell people all about it, how it works, et cetera. Health coaching is key. I've got more employers concerned about helping their employees navigate the healthcare system than I do focusing on some of the other areas. Again, I talked about all the benefits we're offering, all the complexity. Having a health coach available face-to-face helps people. And I don't mean somebody calling them at night during dinner. I'm talking about someone that actually helps them, guide them through the system. Transparency tools I mentioned are key. On-site clinics, and a big movement is shared in multi-employer clinics. We have 6, 7 employers using the same clinic operation nearby is helpful. We talked about direct contracting, centers of excellence. We talked about specialty drugs, incentive programs, high-performance networks, not based on lowest cost, but based on quality data and lower cost. And surcharges for tobacco use, for spouses who have access to care through another source. These are all things to look at. Ultimately, what I'm seeing is that employers are moving from an employer-centric to an employer-facilitated type of health care. The HR Policy Association, again, a group of the largest companies and senior VPs of HR, found that today 95% of employers are centric. In other words, they decide the benefits. They decide where people go. They decide all these things, and only 5 are facilitated. But that will change within the next 10 years. 35% will stay that way. Most will move. I've got an employer who even gives their employees not only a choice of plans, a choice of what networks they want, but also a choice what pharmacy, what formulary do they want. Do they want the limited formulary at the lowest cost, or do they want to pay more for the largest formulary? Giving a lot of information back to employees, facilitating the choices, giving people the tools that make them effective as they are in buying a car or buying a TV, giving them the information on cost and quality and how it affects them. To get sustainable change in healthcare, employers have to play a role. I've learned in my career there's only two things that motivate physicians, hospitals, and others. That's reputation and revenue. Employers need to demand the best of what they're buying. There's got to be a financial reason for doing so, and the market has to demand it. Our employees have to say, we will make the change. Give you an example. Over 10 years ago, one of my sister coalitions, the Business Healthcare Group in Minneapolis, created the first tiered network. They invited all the major health systems in the Minnesota, Minneapolis, St. Paul area to bid on the employers in that community, and we're talking about 3M, we're talking about Honeywell, groups like that, and to bid on quality and cost. And the coalition built 3 tiers: high quality, high cost, minimum cost, minimum quality, low cost, low quality. The employers then got bids. And who was on the top? Park Nicollet Mayo Clinic was on top. High quality, high cost. There were a number of other major hospitals, middle cost. Within 3 months after the open enrollment period, so many employees moved from Mayo Nicollet to the middle cost tier that Mayo and Park Nicollet dropped their cost. They would not have done that if the market didn't demand it. This is what we have to do. We have to motivate what's going on so that at the end of the day, you have a choice. Do we want to continue to have a system based on competition, fragmentation, uncertainty, lack of information, and waste? Or do we want to move to one built on partnership and collaboration, accountability, transparency, engagement, talent, and value and knowledge? It's your choice. Thank you very much for coming today.